Welcome to today's webinar, Update on Emergency Contraception, Options, Effectiveness, Ongoing Use, and Access Issues, which is part one of ARHP's three-part webinar series on emergency contraception. I'm Melissa Werner, Director of Education at ARHP, and it's my pleasure to serve as moderator today. Before we get started on our presentation, I have a few announcements to make. First, to receive continuing education credit for this activity, you must take the pre- and post-tests. If you have not taken the pretest and you are viewing this webinar live, you will find the pretest link in your reminder email. The post-test link will be sent to you after the webinar. If you are viewing this webinar on demand, both the pre- and post-test links can be found below this video. In the webinar dashboard, you should see a chat box that you can use to enter questions throughout the webinar. Our faculty will answer as many questions as possible toward the end of the webinar. In 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you have learned during this webinar into your work. Completing the pre- and post-test as well as this follow-up evaluation helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. ARHP would like to acknowledge that today's webinar was made possible through an independent educational grant from Efficacy. On this slide, you'll see the Planning Committee disclosures of financial relationships with commercial interests. As you can see, Dr. Aisha Mays is a Merck Nexplanon trainer and a trainer for Upstream USA. All other planners have nothing to disclose. Here are our learning objectives for today. By the end of our hour together, we sincerely hope that you will be able to do the following related to emergency contraception, or EC for short. Describe options available in the U.S., provide evidence-based information about efficacy, describe the impact of body weight on efficacy, address questions about use as primary ongoing contraceptive methods, address questions about EC use as a primary ongoing contraceptive method, and describe barriers to access in the U.S. This time, I would like to go ahead and introduce today's wonderful presenters, Drs. Pelin Batur and Kathy Basink. Pelin Batur did her internal medicine residency and women's health fellowship at the Cleveland Clinic. She is the education director for the Primary Care Women's Health Program, the deputy editor for the Cleveland Clinic Journal of Medicine, and holds a faculty position with Cleveland Clinic Lerner College of Medicine of Case Western University. She lectures frequently on a variety of women's health topics to endocrinology, gynecology, and general medicine audiences both regionally and nationally, with a special focus on contraception. She works closely with multiple national medical organizations, including ACOG, ARHP, ACP, SGIM, and the American Board of Internal Medicine. Kathy Basink is a professor of pharmacy and the chair of experiential and continuing education at the Loma Linda University School of Pharmacy. Her clinical practice area is community pharmacy, and she specializes in women's health and public health issues. She is actively involved with several professional organizations, including ARHP, the California Pharmacists Association, the Los Angeles Safe Opioid Prescribing Task Force, the California Society of Health System Pharmacists, and the American Association of Colleges of Pharmacy. So we've got some incredible experts here today. I also would like to give a shout out to Kelly Cleveland, goddess of all things EC, who has served as the consultant project manager and medical writer on this program. We're thrilled to have all of them with us on this webinar today, and without further ado, I'll turn the webinar over to Kathy.
So thank you. Let's begin our discussion about emergency contraception by thinking a little bit about the woman in this slide, the concerns that she might have, and the things that she may be considering. Emergency contraception provides a woman with a second chance to avoid pregnancy in the instance where she may have had a contraceptive failure or a failure to use a method of contraception. The most common reasons for seeking emergency contraception are failure of a method, usually a barrier method, or failure to use a method during intercourse. The emergency contraceptive methods that we're going to be talking about today, both pills and the copper IUD, offer women in these circumstances an opportunity postcoitally to prevent pregnancy. Next. So let's take an audience poll. What percent of sexually active women in the United States, in your estimation, have ever used an emergency contraceptive? According to the most recent National Survey of Family Growth, the answer is 20%, and that's been correctly identified by most of you in the audience. Some of you overestimated a little bit, and some of you underestimated it with 4%. 4% was the percent in 2002, so we have made some significant progress, but the number is still rather low considering in the United States that half of all of our pregnancies are unintended. Although we do have highly effective contraceptive methods and they've been available for several decades, many pregnancies are still unintended or mistimed. And knowing that, when emergency contraceptive has the potential to reduce a woman's chance of unintended pregnancy after unprotected intercourse, the availability and the proper usage of emergency contraception is a very important thing for all women and providers. Next. Oops. Okay, so we will start with a review of the emergency contraception methods available in the United States, and I'll be discussing those in the order of ease of access. Levonorgestrel, which will be abbreviated on many of the slides as LNG, is the most commonly available form of emergency contraception. It is available over the counter for all persons, regardless of age or gender. The one-dose forms of the Levonorgestrel products have largely replaced the older two-dose products. There are many brand names for these products. Some of them are displayed here on your slide. It's an important thing when you're talking with your patients to mention to them, especially if you're counseling them to go to a pharmacy or another store to get emergency contraception, that the package label is going to tell them that the pills must be taken within 72 hours after intercourse. However, there is significant evidence that progestin-only emergency contraceptive pills may be effective up to as long as 120 hours after intercourse. It's important to note that to your patients because that can result in some confusion when they take a look at the package. I like to warn women that they're going to see that. Women should be advised to take the Levonorgestrel as soon as possible. Although they have more time, out to 120 hours, it's very critical that a woman takes the product as soon as she has access to it because of the method by which these pills work, which is to inhibit or delay ovulation. So the sooner she takes it, the more likely she'll be benefited by taking it. There is no need to provide a pregnancy test or have a woman do a pregnancy test prior to using Levonorgestrel. The product is safe in the event that the woman was pregnant, and using a pregnancy test can delay taking the pills, which can increase the risk that they don't work. So all of these products are available over the counter for easy access. The second type of pill form of emergency contraception is ELA, or Ulipristal acetate, which is going to be abbreviated on many slides as UPA. It's been available in the United States since 2010. It is prescription only in the United States, although it has been approved for sale without a prescription in some other countries, including Europe. There is no need, as with Levonorgestrel, to have a woman do a pregnancy test prior to providing UPA. And a couple of features about this product that are important to note is that it's the only product that is actually labeled for use up to 120 hours after unprotected intercourse. However, as with Levonorgestrel, it works by inhibiting ovulation, so it should be taken as soon as possible. I would like to also point out that in a growing number of states that include Washington State, California, and Oregon, pharmacists have prescriptive authority for emergency contraception, which may allow them to prescribe UPA. So women may be able to go directly to a pharmacist to receive UPA. Next. The copper IUD is the most effective method of emergency contraception available in the United States today. Unfortunately, this method remains underutilized, perhaps due to some difficulties with access and due to a lack of awareness by some consumers. The use of this copper IUD has been documented for at least 40 years, and the guidelines for insertion of an IUD recommend inserting within 5 days of intercourse. However, evidence shows that the IUD is effective at any point during the menstrual cycle as long as pregnancy has been ruled out. In addition to being effective as an emergency contraceptive, the copper IUD is also effective and may be effective for as long as 12 years for ongoing contraception. The last method that I'm going to review today is the combined hormonal contraceptive pills, which are also referred to as the Yuzpe method. Combined hormonal contraceptives can be used for emergency contraception. The slide shows a sample of the types of pills that can be used. Of note, all of the pills that will appear in the Yuzpe method do contain either levonorgestrel or norgestrel, as it has been the hormone that has been documented to be most effective. This method requires that a woman take 2 doses and a varying number of pills depending on the concentration of levonorgestrel in the pills that she has. The first dose should be taken again as soon as possible, within 120 hours after unprotected intercourse, and the second dose should be taken 12 hours later. You can access a chart with a more comprehensive list of the combined hormonal contraceptive regimens that can be used at the Not Too Late website, and the website is listed there on the slide, so if you want to jot it down or refer to it later, you can. The Yuzpe method has largely been replaced by the dedicated emergency contraceptive products because they are more dedicated products with levonorgestrel or UPA are more effective, cause fewer side effects, and are far more convenient because they're single dose as opposed to having to take 2 doses. The use of the Yuzpe method should be considered only when other methods, including levonorgestrel, UPA, or the copper IUD, are not available. We're going to move now to discuss the effectiveness of the various emergency contraception methods, and we're going to compare the methods to one another. So if you look at the slide, this demonstrates sort of a hierarchy of the effectiveness of emergency contraceptive products. You can see that the copper IUD is by far the most effective method, with an efficacy of nearly 100% at preventing pregnancy after intercourse, and again offers the advantage of providing ongoing contraception for up to 12 years. UPA is the second most effective option, and we'll talk about why UPA seems to be more effective than levonorgestrel in upcoming slides. Levonorgestrel is the most common and easiest to get method, but again, it may be less effective than UPA. And the Yuzpe method, of course, is an important option to keep in mind when other methods cannot be accessed, as it does have some efficacy even if it's lower than the other methods. It's a little difficult to calculate exactly how effective an emergency contraceptive can be, so this slide, again, gives you sort of a hierarchy approach rather than a numeric approach. Next. There. So this slide takes a little bit more numeric approach. We are going to go through each method individually, but this graphic gives you sort of a one picture approach to thinking about efficacy of emergency contraception. And this graphic shows the number of pregnancies that would be expected among 1,000 women who each had an episode of unprotected intercourse. It's important to note that most women will not get pregnant after one act of unprotected intercourse, and a woman's individual risk is dependent on many factors, including where she is in her cycle, how fertile she is in general, and many other factors. So this graphic is sometimes helpful when you're communicating with patients about what the odds are or how effective it is, because I do get asked that question by women who come in to see me. As we've discussed before, you can see that the blue, or the copper IUD, is by far the most effective option for emergency contraception. So if 1,000 women had unprotected intercourse, one woman might be expected to get pregnant. Maybe not even one, but there's no way to show zero. On the next row, you see the light purple, and that represents the number of women who would be expected to become pregnant after taking Ulipristal acetate. So that number is about 4, higher than the IUD, but lower than the next line, which is Levonorgestrel, the sort of bright pinkish color. About 10 women out of 1,000 would be expected to get pregnant after using Levonorgestrel. And in the yellow, you can see the Yuzpe method, which shows about 20 women who might become pregnant after using the Yuzpe method for preventing pregnancy after intercourse. In the green, we see that women using no method at all, about 80 would get pregnant. So all methods of emergency contraception are far more effective than not using a method at all. And that's really the take-home point that's important to give our patients. Next. Oops. Yep. So let's talk about the methods individually, and we'll start first with the copper IUD, which is 99.9% effective in preventing pregnancy after unprotected intercourse. The use of the copper IUD is not nearly as widespread in the United States as perhaps it could and should be, especially considering its documented efficacy for more than 40 years. A 2012 study reviewed all the literature in English and Chinese describing the use of an IUD as emergency contraception. And among the 42 studies that were cited, there were only 6 pregnancies total among nearly 7,000 IUD insertions after intercourse. So you can see that the efficacy of the copper IUD is quite high. Difficulties in getting into a provider in the limited time available, and a lack in some cases of awareness that the IUD can be a highly effective method may be contributing to its low use in the United States. Next. So if we think now about the effectiveness of Ulipristal versus Levonorgestrel, the two more commonly utilized pill forms of emergency contraception. Ulipristal appears to be more effective than Levonorgestrel in randomized clinical trial comparing the two regimens. UPA prevented significantly more pregnancies than did Levonorgestrel. So in this study, which was between 72 and 120 hours after unprotected intercourse, all the pregnancies that were found in the study occurred in the Levonorgestrel group. So UPA is significantly more effective. The greater efficacy of UPA appears to be due to both how and when it works. So UPA is more effective than levonorgestrel in postponing imminent ovulation. So if you look on the slide, you can see that UPA prevents ovulation 100% of the time when taken prior to the LH surge, 79% of the time when taken prior to the LH peak, but only 8% of the time when taken after the LH peak. If you looked at similar numbers for levonorgestrel, you would find that levonorgestrel works up to the LH surge, but is not effective or not as effective when taken after the LH surge. So it follows that UPA, because it works over a broader window, if you want to look at it that way, up to the LH peak, may be more effective than levonorgestrel. Thinking a little bit about effectiveness and timing, emergency contraceptive pills, which would be the UPA and levonorgestrel, should be taken within 120 hours or 5 days after unprotected intercourse. Women may be very concerned about this time limitation, and they may also take the approach that, oh, I have a lot of time. So it's very important to emphasize that although the label says it may be taken up to a certain time, ideally it should be taken as soon as possible. Again, reminding you that the label for levonorgestrel does say 3 days, but the studies show that it does work up to 4 or 5 days. And it's important to counsel women, if you're going to be sending her to purchase over-the-counter products, that what's on the label has been really replaced in the medical literature with knowledge that it can work even later. The label for Ella, which is prescription only at this point in time, does say it can be taken up to 5 days with no loss in efficacy. Again, you want to emphasize that all these pill products work by preventing or delaying ovulation, and depending on where a woman is in her cycle, she may not have 5 days to wait. Women may not know where they are in a cycle, and my perspective is just to encourage women to take it as soon as possible so they have the maximum possible benefit from taking the product. When it comes to the copper IUD, many but not all guidelines recommend the use of the copper IUD similarly to the pills within 5 days of unprotected intercourse or ovulation to minimize the chance of disrupting implantation. However, one analysis has shown that the IUD is effective at any point in the menstrual cycle as long as pregnancy has been ruled out. If a woman is seeking emergency contraception and is interested in the copper IUD, try to place that IUD the same day if at all possible so that logistics will not get in the way of her having access and utilizing the method, because we do know it is the most effective method. So a hot topic in recent years has centered around the effectiveness of emergency contraception in women either with a high BMI or high body weight. So we're going to do another audience poll. In the past year, how many patients have asked you about whether emergency contraception would be less effective for them because of their weight? So most of you say no one has asked you about weight, and that actually kind of goes along with what I see as well. A few of you have had some patients, and some of you have had quite a few. So next, let's talk a little bit about what we actually know when it comes to weight and the efficacy of emergency contraception. So this slide shows What we already know about increasing BMI and weight and the efficacy of both Ulipristal and Levonorgestrel. And this chart shows that there may be a reduction and fairly a rapid, especially with Levonorgestrel, decrease in efficacy with increasing BMI. And this really raised a lot of concerns. Next. These concerns have led regulatory agencies to go through a little bit of a struggle over the last few years in dealing with this issue of weight and BMI. In 2013, based on a little more analysis of the data that we have, the European regulators changed the labeling for Norlevo, which is the Levonorgestrel product, warning that it might be less effective for women who weigh 165 pounds or more, or even maybe ineffective in women who weigh more than 176 pounds. Additional data, however, was reviewed, and the European Medicines Agency determined that the data really weren't sufficient to warrant this labeling, and in 2014 ordered the language to be removed from the labeling. In 2016, here in the United States, the FDA concluded its own review of data and determined that the data were conflicting and too limited to reach a definitive conclusion on the question. The FDA has encouraged EC manufacturers to do further research on this question of weight and efficacy. And that has led to some additional research on the pharmacokinetics of these two agents. So there have been a couple of studies. One of them is depicted here on the study, and I'm going to talk about both studies in the next couple of slides. Taking a look at pharmacokinetics. The study that's depicted on this slide looked at 5 women, a small number, who were of normal BMI and 5 who were obese. Each of them were given the usual 1.5 milligram dose of Levonorgestrel, and serum concentration levels and areas under the curve were calculated in both populations. Following this, the women who were obese were given a dose of 3 milligrams of Levonorgestrel, and the same pharmacokinetic studies were conducted. The second study looked at a slightly larger number of women and was a crossover with Levonorgestrel and UPA. And on the next slide, we'll see some combined data from the studies. What you can see here is that in women who, if you're comparing women who are obese with women who have a normal BMI, when given the 1.5 milligram dose of Levonorgestrel, obese women showed a lower serum concentration of Levonorgestrel than women of normal body weight. This was true in both studies. In the study that looked at the double dose of Levonorgestrel in women who were obese, they found that the serum levels from the double dose were about equal to those of women who had a normal BMI who only received the 1.5 milligram dose. We don't know if serum levels are the best marker of efficacy. We don't know how serum levels translate exactly to efficacy with emergency contraception, but you can see that there is some evidence that the dose and body weight may have some significance that we need to follow going forward. Further research is definitely needed, but doubling the dose of Levonorgestrel may not be feasible for all women. Not only does that increase the cost of emergency contraception significantly, we're not 100% sure that serum levels are the only answer to what's going on in women who are obese taking emergency contraception. And that's illustrated by a study that showed that a half dose of levonorgestrel, 75 milligrams, also was effective in disrupting ovulation. And it was as effective as the standard dose. So there's a lot more to come here. But keep in mind, as you talk to women, if they do ask, this is the data that we have. So efficacy and weight, the kind of take-home messages for women, the IUD does not lose effectiveness regardless of weight. So the IUD can always be recommended. Women who have a high BMI may consider a double dose of levonorgestrel. It's safe. Based on the data we have, it may be more effective, but we really can't say that for sure. I would highly encourage you not to deny emergency contraceptive pills to any woman due to her body weight, and regardless of which type of pill product she decides or you have available for her to take, they should be taken as soon as possible. So with that, I'm going to turn it over to Dr. Batur, who's going to talk about some clinical and access issues related to emergency contraception methods.
Thank you very much, Kathy. Hi, I'm Helen Batur, and before I get started on my portion, I did want to again say thank you to Kelly Cleland, who really helped oversee and organize this entire project. So thank you, and she'll be joining the call during the question and answer session for any of her insights. And I probably will annoy all of you with a little tickle in my throat. It's a beautiful time in Cleveland right now, but we have these string of parks that gives us all these little allergic coughs. So sorry about that in advance. All right, so I'm going to talk to you about ongoing use of EC as a primary or ongoing method, because some patients may want to ask you about this. So these may be women who have sex pretty infrequently or those who have difficulty accessing or using other methods. Some patients may be using this as a default method because they find it easy to use, and some just may not realize it's not as effective as an ongoing contraceptive method. So we'll talk about what's known with repeat use of EC so that you can counsel your patients on the best option for them. So a recent study by the World Health Organization looked at ongoing use of levonorgestrel 1.5 milligrams. So these were over 300 healthy fertile women who reported sexual intercourse up to 6 days a month. So they asked the women in this study to use levonorgestrel 1.5 milligrams each time they had sex, and it was over a period of 6 months. So amongst the most fertile subsample, which would be those younger than age 35, there were 10.3 pregnancies per 100 women years of use. And this rate is similar to other coitus-dependent methods. And side effects, luckily, were generally mild and tolerable. They included headache, nausea, and abdominal pain. So keep in mind, this was a single-arm study with a small sample size and without a control group. It was really designed as a proof of concept study to explore the feasibility of this type of contraception. Next slide. If we look at UPA, a more recent pharmacodynamic study investigated the regular use of UPA-EC. In this study, women took UPA every 5 to 7 days. And what they did is they did transvaginal ultrasound and hormonal measurements at each regular study visit. So most of these patients experienced normal ovulation at some point in the study. And similar to the levonorgestrel study, side effects were generally mild and tolerable and include headache, nausea, menstrual disturbances, and abdominal pain. So that was reassuring. So this is a method that's safe and tolerable, but it's probably not going to be a highly effective one for ongoing use. Now, keep in mind, some failures will always occur among EC users, so we frequently get the question about safety from our colleagues. And what's the safety of UPA on resulting pregnancies? We're going to go in, you're going to go into much more detail in the second webinar about safety, but just to touch on that quickly, it's not on the slide, but a recent pharmacovigilance study of UPA found over 200 pregnancies with a known outcome, and among these, there were no differences in the rates of spontaneous abortion or ectopic pregnancy as compared to the general population. And in right under half of these cases, it was unknown whether the UPA was taken before or after conception. And another study I really like to quote is the Levy's group that they published in Contraception in 2014. It was looking at the post-marketing surveillance data of over 1.4 million women exposed to UPA for EC worldwide. And luckily, very few serious events were reported other than pregnancy, and similarly, pregnancy complications were not increased. So if you want to hear more about side effects, join in on the second webinar. So the messages for patients: oral EC generally stays in the body for 24 hours, so there's no need to repeat EC within 24 hours. So because of concerns about mixing progestins and antiprogestins like UPA, it's not recommended that you take them within 5 days of each other. And again, we're going to go into that in the future webinars. The most recent ACOG guideline on EC confirms that using EC more than once within a cycle is safe and reasonable. But we need to remind our patients that this is not the best way to prevent pregnancy. You need something ongoing to be more effective. And remind patients that EC may prevent pregnancy, but they're still at risk for STIs. And finally, those who find themselves needing EC frequently are great candidates for a highly effective contraceptive option. Make sure that the patient knows that the copper IUD is the most effective method for EC. And if that is a possibility for her, support her in getting that method, especially that day if possible. Which brings us to our next slide, our next point, which is access to emergency contraception. Should advance? Perfect. So there are a lot of barriers to accessing EC still, unfortunately, and we need to keep these in mind when working with our patients. Because EC pills are more effective the sooner they're taken, any barriers that result in delays work against the patient and can increase the risk of pregnancy. Next slide. Cost can be a major barrier for women who need EC. The copper IUD should be covered by insurance plans under the contraceptive coverage provision of the Affordable Care Act, but this does not, unfortunately, apply to every plan. And who knows what's going to happen with this moving forward. UPA costs about $50 for patients paying out of pocket. Patients can get it online for $67. That includes next day shipping. And the Levonorgestrel EC is a little cheaper, $40 to $50. They can get it online for $20, but that's without expedited shipping. So that's not a good option for women who need it right away, but maybe if they want to have it in their nightstand table. Next slide. All right. So awareness of the copper IUD as EC among providers is still very low. There's that Cleveland cough, sorry. And some providers may still have concerns about providing IUDs for young women and nulliparous women. So for the copper IUD, we need to consider that not everyone wants one. And some women may be uncomfortable with the idea of a device in their uterus, and others may not like the bleeding profile. So although UPA has been approved for 7 years in the US, it's still not widely known or used. Awareness among providers is low. Kelly Cleveland and I worked on a study that was pretty interesting, eye-opening. We surveyed a significant number of several large tertiary care academic institutions, and we looked at both reproductive and non-reproductive health providers, but people on the front lines getting these calls from patients. And unfortunately, only half of reproductive health specialists at that time had heard of UPA, while only 20%, 1/5 of non-reproductive health specialists were aware of it. And when it comes to provision, as providers, we do even worse. So in terms of prescribing or offering EC to women, only 14% of reproductive health providers prescribe UPA, and only 4% of non-reproductive health specialists. So that includes our ER folks. So as we'll discuss in the next slide, if we can click over, while the awareness of Levonorgestrel EC is far more widespread than for UPA, there's still a lot of confusion about Levonorgestrel EC and how it's sold. So that actually is a barrier to use as well. So several factors impact the availability of EC methods. Okay. For the IUD, even when providers are aware of the copper IUD as EC and want to offer it, in the clinic, you can't always make it happen as the same day, okay? And it sometimes can be even hard to get the patient within the next week, within that same week. One barrier to the wider spread use of UPA is that many pharmacies still do not routinely stock it. In fact, there was a study in Hawaii showed less than 3% of pharmacies had UPA immediately available. And this might be partly due to the fact that we're not writing for it as much, or we're not recommending it as much. And after years of regulatory battle, Levonorgestrel EC is finally fully available over the counter, and it's without age or point of sale restriction. So in theory, a man or woman of any age can walk into a store and buy EC without having to show ID, but we know in the real world it doesn't always work like that. And this is a huge step forward that it's approved for unrestricted sale. But barriers remain for this as well. So many stores don't stock it on the EC shelf, or they stock it in a locked box case, locked box or a case. And you know, these regulations and age restrictions have changed so much in recent years that there's still a lot of confusion out there about the regulatory status. So people just aren't aware of the freedom of patients to go get their EC. In a recent survey from the American Society of EC, 40% of respondents were told by pharmacy staff that there's still an age restriction on the purchase, unfortunately. Next slide. All right, so insurance can be considered both a barrier and a facilitator to access. So when it works as it should be working, insurance is great, and it's a critically important aspect of getting the EC. But you know, although the contraceptive coverage mandate of the Affordable Care Act should cover all these methods without cost sharing, we know in practice that doesn't always happen. Working on the Women's Preventative Service Initiative of ACOG, we've tried to write the verbiage to minimize insurance companies going around this, but you still can't control what happens out in the real world. So only one product per category is required to be covered, so that's how sometimes insurances can get around this. The Kaiser Family Foundation found that only 11 out of 20 plans reviewed covered Ella without copay or reasonable medical management. And I mean, reasonable medical management, that's silly. We got to get this to the patient's hands within 5 days. And so, of course, even in plans that are covering all EC methods currently, so we don't know the future with our current political climate, so we don't know if plans will continue with this coverage. Prescription is generally required. There are some states, such as Maryland, which are starting to require that insurance plans include coverage of over-the-counter contraception. But really, this is still an exception, and implementation has been a big challenge. So it's interesting, I've read that there's really bipartisan support for this concept for over-the-counter access, but the sticky point a lot of times is who's going to pay for it. And we know if it goes over-the-counter and insurances are not picking it up, that's going to become a huge barrier. All right, next slide. So with access solutions, advanced prescription. So one way that we can help is to write an advanced prescription for Ulipristal acetate, so they can take it as soon as they've had unprotected sex. If they fill the prescription right away, then they can have it on hand in their purse, in their nightstand, wherever, so that they have it at the time of need. This is probably most important for women who have a lot of travel or cost barriers to getting to a clinic. It's best to provide a paper prescription instead of electronically e-scripting it, again, so that they have the option to take it to different pharmacies, because some of the pharmacies, or many of the pharmacies, aren't going to have UPA in stock. And remind the patient that she can still use the prescription for up to a year after it's written. And I've had to ask a lot of my partners who don't do as much women's health that, okay, if a patient calls asking for it, please refill the prescription on my behalf. You don't have to go through any kind of checklist or protocols. So if you're providing an advanced prescription, remind your patient not to start or resume oral contraceptives or a patch or a ring within 5 days of unprotected sex after she takes the UPA. And this is because of concerns that the progestin in the contraceptive will counteract the effects of the UPA, making it less effective. And we're going to go into that in great detail in our next webinar. So for women who want to use their insurance to cover levonorgestrel emergency contraception, many will need a prescription. So again, writing a prescription in advance will help a woman who needs it right away and get it covered by her insurance without having to wait for a clinic visit. All right, and next slide. So for the Yuzpe method, while we know it's not a first choice option due to how patients tolerate it and the lower efficacy, in some situations, it may be the only thing we've got. So especially for women who are living in rural areas with few pharmacies or healthcare providers, so this can be important. Some states are supporting a 13-month supply of OCs. We did write for that with the Women's Preventive Services, again, at ACOG, but that really is insurance dependent. But if she is able to get a 13-month supply, then that means she already has a ready EC option on hand if she needs it. Okay, next slide. So let's do a case study. This is Monica. And Monica she comes to your clinic and tells you that she had unprotected sex 3 days ago. She knows that there's something that she can do, but she's not sure. She doesn't have a lot of information. She's very stressed. She really can't get pregnant right now. Maybe she's in school, maybe financial, maybe whatever, but she doesn't want to get pregnant. So she weighs 190 pounds, and she tells you that she really doesn't like the idea of a long-term contraceptive. Next slide. So how can we help Monica? So she's communicated to you that she's not comfortable with the idea of long-acting method, and we want to respect her thoughts. But you do want to make sure you answer any questions that she has so that she doesn't, so she's not really believing in some of the myths, and you can dispel these myths. So I find that patients really worry about the pain of the procedure. And what I've found works is I tell patients, well, this is not going to be a scream out loud kind of discomfort, but just to hold my breath for a few seconds type of pain. And that seems to resonate well with patients. They're also concerned, I find, about migration or perforation. Nice thing is we have that the US study from 2015 that was published in Contraception, and it reviewed with us how the results of perforation migration is very low. And we're going to go into that with our next webinar. We also want to remind her that just because a method can be long-acting, it doesn't mean it has to be. So it doesn't mean she has to keep it in for a long time. So make sure that she knows that the IUD can be removed at any time, and it's a very, very simple process. It's not a big procedure. It takes only a few seconds. Patients don't really realize that. Since Monica weighs 190 pounds and she had sex 3 days ago, UPA is going to be the next best option. So just as a reminder, it's more effective for anyone in that weight range. For patients who weigh more than 165 pounds, offering UPA first is going to be especially important. The last CDC data that I saw on the average American woman, she is about 166 pounds. So this is going to be relevant to most of the average patients that we see in our practice. And keep in mind, again, UPA isn't always available at pharmacies. So if your clinic doesn't stock it, I know mine doesn't, we have to help her find some pharmacies where they will prescribe it, local pharmacies, and also help her to check with her insurance. Next slide. All right, so in addition to giving her the UPA today, we want to offer another paper prescription for her so that she can keep it on hand in case she needs it again. And just let her know that if she does use it, she shouldn't use a hormonal contraceptive within 5 days of when she had unprotected sex. Again, we're going to go into that in great detail at our next webinar, and we hope you'll join us for that. It'll be going into side effects and some of these practical issues of interactions, and then the third one is going to be the frequently asked questions. And then you want to offer her help if she'd like to start to use an ongoing method in the future. It doesn't have to be a copper IUD. Patient education materials can be very helpful. Go ahead and go forward one more, please. We have some additional resources. Bedsider.org is a free support network for birth control, really intended for women 18 to 29, but you can use it for any age woman, operated by the National Campaign to prevent teen and unplanned pregnancy. And then the American Society for Emergency Contraception promotes access to EC in the United States. It's a very valuable website. The EC website is operated by the Office of Population Research at Princeton, which Kelly helps oversee and is involved with, and also by the Association of Reproductive Health Professionals, and it has up-to-date evidence-based information about EC. And so keep in mind that these resources are not connected with any companies that manufacture or sell emergency contraceptives. So no financial disclosures or conflicts of interest here. Okay, you can go one more. Next. And we have our list of references for anybody who would like to go back and review them more in detail. And that's it from my end. We're open for question and answers.
Yeah,
and thank you everyone for joining us.
Thank you so much, Kathy and Pelin, for that excellent presentation. And we are going to move on and answer some audience questions. The first one I see here is from Ashley, who asks, can women use emergency contraception while breastfeeding?
Yes, they absolutely can. The first thing to consider is whether she actually needs emergency contraception. Keep in mind, if she's breastfeeding and she meets 3 criteria, she may not even need EC. So if she's within 6 months postpartum, if she's fully amenorrheic and exclusively breastfeeding, so that means at least 85% of the feeds are breastfeeds, she may not need EC. But for women who otherwise need EC, copper, of course, is going to be the best. There is slightly increased proliferation rate in women who are breastfeeding, but the absolute risk is still low, and we're going to go through that in the next webinar. There's no restriction at all to the Levonorgestrel EC. She doesn't have to pump or dump or anything like that. For Ulipristal, even though the U.S. package insert doesn't recommend it, the research suggests that it's safe. So we have different guidelines to guide us. The U.S. MEC says you want to pump and dump and then can resume breastfeeding 24 hours later. And the UK guidelines are a little bit more conservative, and they say for 1 week. I don't know if anybody else has anything to add to that.
Kathy, anything to add?
No, I think you covered it quite well.
Great, thank you so much. We have another question here from Andrea, who asks, if a patient takes EC multiple times, especially per cycle, can it have a detrimental effect on a woman's reproductive system?
No. That's why the ACOG committee says it's safe to do that. So it's just delaying ovulation, but it can cause some mild menstrual irregularities or some bloating or headache. But no, it's not going to impact, future fertility or cyst formation or anything like that.
Thank you. And I have a question from another Andrea, if I'm pronouncing her name correctly, who would like to know, how do you suggest you communicate with pharmacies that don't carry UPA and in some cases don't know about and don't realize why it's important to carry it in addition to LNG EC?
So I'll take that one, being the pharmacist. I would say the most important thing to do is establish a relationship with the pharmacy and let them know that you will be writing prescriptions. The main concern that many pharmacies have is sort of inventory control, and if they're going to keep something in stock, they want to know that there'll be some prescriptions for it so that it doesn't expire and, essentially go out of date sitting on the shelf. So one important thing would be to let them know that you will be prescribing it. The other thing to communicate would be to talk to them about coverage and how to work with insurance companies to make sure that the product is covered in the way that it should be.
Thank you. Mickey would like to know, what do you tell women about mechanisms of action of the copper IUD?
Okay, I can take that one. So we're going to go into that in our second webinar, but it's the copper ions that are thought to affect sperm and even egg mobility and function. So that's really so it's similar to the contraceptive efficacy. Kathy, did you have anything else to add?
No, I don't get a lot of women who ask that question.
All right, thank you. We do have one more question before we wrap this up. From Barbara, we have no age restriction in any state on OTC purchase of LNG. So is that true that there's no restriction in any state? Also, what about obese patients with UPA? No evidence that taking more may be effective. May be better appears to possibly be the case with LNG and doubling dose.
So I'll take the first question, which is about the age restrictions. And there are no age restrictions for 1.5 milligram Levonorgestrel tablets in any state. It can be sold without restriction to a man, to a woman, to someone over 18, to someone under 18, and it should be readily available to any consumer who would like to purchase it in any quantity that they would like to purchase.
Yeah, and I'll take the second part. In terms of doubling Levonorgestrel EC, I know a lot of providers are doing that because there's no concerns with safety. There's less data about UPA, doubling of that, so I would not recommend that. And, you know, I think the big picture to keep in mind, the World Health Organization did a study, and I think they just published it, it was early this year or late last year, and really pregnancy rates remained low, even with Levonorgestrel EC use, not doubled with its current way, the current, 1.5 milligrams across all BMI categories. It was, less than 3%. So, weight is never a reason to withhold EC, but for somebody who's really nervous and who can afford doubling the Levonorgestrel, go ahead. But for UPA, there's really no good data right now to suggest that's needed or safe, or I don't know if Kelly has anything to add to that.
Okay, it sounds like that was a pretty thorough answer. Thank you. And we have just a couple of minutes left. I have one additional question that just came in. This will be our last. Can you tell us more about when you think UPA may be available over the counter in the U.S.?
I don't think there's an estimated date for that, but I know that there is interest in having that happen, and there is activity in making that happen ongoing, and until the application is filed, we won't know for sure.
Okay, great. Thank you again to Helen and Kathy for joining us today and for all these great questions. As you've heard a few times, today's webinar was the first in a three-part series. The next two webinars, which you can see on this slide, will take place on October 18th and November 20th. You can register for both of them at arhp.org. You can also access, next slide please. Okay, great, thanks. You can also access patient and provider resources on EC and many other topics on our website. And the recording for this webinar and accompanying slide deck will both be available shortly on our website. As a reminder, please be on the lookout for an email from ARHP's Education Department with a link to the post-test survey. Your CME or CE certificate will be generated at the end of the survey. Be sure to print the certificate before closing the internet browser. And if you have questions about this or anything else, do feel free to email us at education@arhp.org. Thank you once again for taking the time to participate in this webinar, and we hope that we will see you soon again in other educational activities hosted by ARHP.